Okay, so we're gonna talk about chemical burns to the eye. It's a very serious and dangerous incident that you should treat very seriously, and you should start the treatment immediately, even before you test the vision, unless you suspect an open globe. So, what kind of chemicals are we talking about? Well, it could be alkali, for example, lye, cement, plasters, airbag powder, bleach, ammonia, and it could also be acids. So, what kind of acids are we talking about? Could be battery acid, pool cleaner, vinegar, as well as other chemical burns like solvents, detergents, and irritant like mace. So, how should we treat it? What's the emergency treatment? So, this is an emergency. How should we treat it? Well, you should do irrigation, irrigation, irrigation. That is the most important thing. Copious but gentle irrigation using saline or ringer lactate for at least 30 minutes. Tap water can also be used if you don't have saline. It Tap water may be more effective actually in inhibiting elevated pH for alkaline burns. Now, it should be noted that you should never use acidic solution to neutralize alkali or vice versa, because this reaction itself can generate harmful effects on the eye. Also, you could use an eyelid speculum and topical anesthesia, for example, uh, proparcaine, um, prior to the irrigation, and because you want to expose the whole eye to it, the upper and lower fornices. They must be everted and irrigated. After exclusion of open globe, uh, maybe there's particles that are in the eye, so they should be flushed or manually removed. Also, manual use of IV tubing that is connected to an irrigation facilitates and makes it easier for you to irrigate. Now you should wait 5 to 10 minutes after irrigation is stopped. So you want to allow the saline to be absorbed. Then check the pH um, in the fornices using a litmus paper, as you can see here in the picture. Um, you should not stop your irrigation until you achieve a neutralized pH, which is 7 to 7.4. Now, the conjunctival fornices should be swept with a wet cotton tipped applicator or a glass rod to remove any particles or that can cause um, of the cause itself, the causative material, and necrotic conjunctiva. Especially in the case of a persistently abnormal pH, you should definitely do that. You should double invert the eyelids with an eyelid retractor. Um, that's very important if you want to identify and remove particles in the deep fornix. Now, calcium hydroxide particles may be more easily removed with a cotton tipped applicator soaked in disodium ethyl endiamine tetraacetic acid. The acidic or base foreign bodies that are embedded in the conjunctiva, cornea, sclera, or surrounding tissue sometimes could require surgical debridement or removal, so you should definitely keep that in mind. Now, for the burns, we can classify them from mild to moderate to severe, and we'll talk about the signs, workup, treatment, and follow up of each one of these. Now, let's start with the signs. Well, there are critical signs that I'll mention first, like CED, SPK, CED corneal epithelial defect, SPK scattered superficial punctate keratopathy, focal epithelial loss, and you could also have sloughing of the entire epithelial. But it should be noted that there's no significant areas of perilimbical ischemia, i.e., no blanching, as you can see here in the severe. If you see blanching, you can see it right here, blanching of the conjunctiva or epicleral vessels. This means that it is severe, it's not mild nor moderate. Other signs like focal areas of defects in the conj or chemosis, hyperemia, hemorrhage, edema, mild AC retraction, maybe second degree burn in the skin surrounding the eye, with or without lash loss. Sometimes when you want to check for CED, you put the fluorescein and you don't see anything. But you still suspect a CED. This could happen because the defect itself is slow to uptake the dye, so you should repeat the fluorescein staining and check again. Because if the entire epithelial sloughs off, only the Bowman membrane remains, which may take up fluorescein poorly. Okay, so we mentioned all the signs in the mild to moderate burn. Now let's talk about the workup. First of all, history. What are we gonna ask in the history? Well, we need to ask of the timing of the injury, type of the chemical, time between the accident till irrigation was started, duration and type of the irrigation. What else should we ask about? Eye protection. Do you have a sample of the agent, a package or a label, or even a material safety data sheet of the label of the irritant itself? That could really help in the treatment itself. So we asked about history, and we also need to do a slit lamp exam. So what do we see in the slit lamp exam? We basically try to see with fluorescein staining as to check for CEDs. We do eyelid diversion to search for foreign bodies, evaluate for conj or corneal ulceration or defects, of course. IOP also, you should check the IOP. Also, in the presence of a distorted cornea, the IOP can be measured with a tono pen most accurately, or a pneumotonometer. Also, if you want to do gentle palpation, you can do that. Now, we talked about the signs, we talked about the workup, let's talk about the treatment. Basically, you do the same emergency treatment we talked about before. You should also give the patient cycloplegic, like scopolamine. You should definitely avoid phenylphorine because it's a vasoconstrictive. You should give topical antibiotics, like erythromycin every 1 or 2 hours. Or you could do a pressure patch for 24 hours. Oral pain medications. Now, if the IOP is elevated, you should definitely treat that and give acetazolamide. But you should monitor the electrolytes, especially potassium. Also, you can give the patient, if the IOP is high, you could give the patient a beta blocker, for example, timolol. If you need even more control, what else can you? You cannot use alpha agonists. You should avoid that because they're vasoconstrictive again. Lastly, you should tell the patient to use frequent artificial tears or gel, whatever suits the patient. Now, for the follow-up, it should be frequent. Initially daily, and then every few days till the CED is healed. Topical steroids may then be used to reduce significant inflammation. You should monitor for corneal epithelial breakdown, stromal thinning, and infection. Now, we're done with the mild to moderate burns. Let's talk about the severe. Now, in the severe burns, signs, addition to the one we mentioned, we have, as we mentioned, the blanching of the conjugate itself. This is typical for a severe burn. Pronounced chemosis, corneal edema, opacification, AC reaction, but you may not appreciate that if the cornea itself is opaque. Other like high IOP, second and third degree burns of the periocular skin, as well as local necrotic retinopathy as a result of the direct penetration of alkali, for example, through the sclera. So these are all severe signs. Now, what about the workup? We do it exactly like the mild to moderate burns, like we talked about. For the treatment, we first start with the emergency treatment we talked about, and hospital admission is rarely needed for close monitoring of IOP and corneal hearing. You should debride the necrotic tissue that is containing of foreign matter. You should give the patient cycloplegic or atropine. Again, never use phenylephrine because it's a vasoconstrictor. You should give topical antibiotic, like trimethoprim polymyxin B, or one of the fluoroquinolones, like erythromycin QID, or you could give bacitracin ointment 4 to 9 times a day. You could also give topical steroids 4 to 9 times a day if there's significant AC or corneal inflammation, or even a combo of antibiotic and steroids, drops or ointment Q1 to 2 hours. Consider also a pressure patch between drops. If the IOP is high, you should also consider anti-glaucoma, as we mentioned. Frequent Q1 hour of artificial tears or gel if not using frequent ointments. You could also use oral tetracycline to reduce the collagen lysis and the stromal melting, for example, doxycycline. Also, if there is conj adhesion, you could do lysis using a glass rod or moistened cotton-tipped applicator covered with antibiotic ointment to sweep the fornices. Other consideration that you can take, so now we've talked about the treatment fully, but there are other consideration as well. You could give the patient therapeutic soft contact lens, collagen shield, an amniotic membrane graft like Procara or sutured or glued, or even if it's a severe case that it did not heal for beyond 2 weeks, you could do tarsorrhaphy. You could also give the patient ascorbate and citrate if it's an alkali burn, because it's been reported that it speeds healing and it has a better outcome. But be cautious in using these because it has renal compromise. If there's melting of the cornea, other collagenase inhibitor could be used, like acetylcysteine. If the melting progresses or the cornea perforates, consider cyanoacrylate tissue adhesive, an emergency patch graft, or corneal transplantation may be necessary. But the prognosis is better if this is performed at least 12 to 18 months after the injury. Okay, for the follow-up, you should monitor it closely and either in the hospital or an outpatient. The topical steroids should be tapered after 7 to 10 days because they can promote corneal melting. You should advise the patient to use the artificial tears Q1 to 6 hours for long term. Because if there's severely dry eye, the patient may require a tarsorrhaphy, as we mentioned, or even a conjunctival flap, or even conjunctival or limbal stem cell transplantation if it didn't heal within several weeks or several months. That is the worst case scenario. So that is it for chemical burns. We have one more thing we can talk about, which is super glue injury to the eyes. The glue itself, it hardens quickly, especially the rapid setting super glue. So we're going to talk about the treatment and the follow-up. How do you treat it? If the eyelids are glued together, you can basically just separate it with gentle traction. Sometimes it's required to cut the lashes to separate the eyelids. Misdirected lashes, hardened glue can mechanically rub the cornea. So you should definitely remove these, and if the glue is stuck to the cornea, that also should be carefully removed. How do you remove it? Use fine forceps, copious irrigation with warm normal saline or warm compressors. You want to loosen the hardened glues and in the lids or the lashes in the cornea. You should loosen that up with some warm compressors. Now, epithelial defects, you should treat them as CED. Warm compressors, QID will help. Follow up daily until the CED are healed. And that is it. Thank you so much. And that was chemical burns to the eyes.